Welcome to the joint meeting of the American Society for Microbiology and the International Society of Chemotherapy here in San Diego for the joint meeting of the 55th Interscience Conference on Antimicrobial Agents and Chemotherapy and the International Congress of Chemotherapy here in San Diego. For those of you joining us for the first time, welcome. This is a meeting whose focus is on antibiotic resistance, antibiotic development, antibiotic stewardship, and this morning we're going to touch on vaccines. This meeting affords the attendees, and now you, an opportunity to discuss and think about collaborations with some of the speakers that we've asked to join us here at ASM Live. I'm Michael Schmidt from ASM's This Week in Microbiology, and it's my honor to discuss some of the science being presented here at ICC-ICAC with some of the authors who have been presenting their science. This morning we're delighted to have with us Dr. Ron Dagan, who is Professor of Pediatrics and Infectious Diseases at the Pediatric Infectious Diseases Unit of Soroka University Medical Center in Israel. Dr. Dagan is going to share with us many of the results that he's been reporting on over the past few days here at ICC-ICAC about vaccines for special populations, uptake, impact, and the challenges. And you presented that on Friday, and it's really a pretty exciting topic. So Dr. Dagan, why don't you review for us the results that you have shared with the ICC-ICAC audience so that our friends out in the web can actually experience some of what you shared yesterday.
Okay, so the specific research I was presenting is about looking at effects of vaccines instead of each separate vaccine and each separate organism to see what the vaccine did, to actually understand that the children don't know which vaccine is given. They get all the vaccines.
All at once.
And they want to see what happens in terms of their health. They are not really very much in care whether they get it because of vaccine A or vaccine B. So most of the reports on rotavirus vaccine and pneumococcal vaccines in children, which are two of the most really important vaccines that were introduced recently, I usually reported as rotavirus success in rotavirus gastroenteritis or pneumococcal vaccine success in pneumococcal diseases. In Israel, we were actually lucky to be able to look at it a little bit differently because unlike United States, we have introduced both pneumococcal conjugate vaccines and rotavirus in about the same period of time.
So you have a great population from which to ask a question.
Right. And in addition, in southern Israel, we have a special situation. We have one hospital for all the children in the area. So they're all born in that hospital and come back to be treated in that hospital. And it's about a cohort of 30,000 children under 2.
So that's a big sample size.
Exactly. So we wanted to look at what happens when the two vaccines are introduced. We had done a lot of studies until they were introduced, so we had the baseline. And we wanted to see how those two co-contribute together to the health of the children.
So you asked the question, do they develop pneumonia? Do they develop diarrhea?
And maybe, yes, but not only that. Pneumonia, some of the pneumonias are very specific to pneumococcus. Some may not be as specific. Diarrhea, some of them are diagnosed as rotavirus, and some of them are not yet diagnosed as rotavirus. So we wanted to see actually the whole effect on respiratory tract infections and gastrointestinal infections, because also, in theory, one success can affect on the other. If you have diarrhea, you may be weakened, and you may get more pneumonia, or vice versa. So we really wanted to see what that's done. In addition, those two diseases are winter diseases. Mm-hmm. So the whole burden of winter, which is very big burden in young children, could be reduced because those two diseases that are greatly reduced by vaccines are reduced at the same time. So this can really relieve the burden of hospital and hospital visits in the winter.
And plus, the parents will be happy too.
Right. I think the parents will be happy. Also, the pediatricians are very happy because they could not really handle, in most of the places in the world, the winter is such of a burden that physicians cannot deliver appropriate treatment because of those diarrheas.
Yeah, their offices are full. Their offices are full.
Exactly.
So, you know, what the global question of looking at the effect of two vaccines on wellness is really goes back to the fundamental value proposition that vaccines offer society. So what did you learn?
So what we learned is as follows, okay? We had a baseline of diseases. So for example, if we take just the classical pneumonia that is associated with pneumococcus, plus the rotavirus positive gastroenteritis, and we look what was their role, just those two, in terms of percentage of all admissions to the hospital under 2 in the winters before vaccination. So 1 out of 5 children admitted to the hospital under 2 had either one of those or both.
Wow. 20% of the population.
20%, 1 out of 5. And we have seen a 78% reduction in the admission, in the rates of admission. So
for
really
both
incidence,
diseases?
No, 78% of rotavirus, 46% of pneumonia. But in addition, the other lower respiratory tract infections, and even those who were not labeled as rotavirus gastroenteritis were going down in a lesser extent. But altogether, we have seen that the 2 vaccines reduced 2,000 cases per 100,000 children per year.
That's phenomenal.
That's phenomenal. If you translate it to the American numbers of 4 million births, it's about 450,000 visits per year to the hospital, and over 150,000 admissions per year in the hospital. So this is really a huge relief, for, of course, for the children.
Only
but
from
also
2 vaccines.
Only for 2 vaccines, and within 3 to 5 years post-vaccination, so you don't have to wait like 20 years before you see it. It's immediate.
This is absolutely incredible, because it really goes to the question of how valuable these vaccines are to society, because the numbers of hospitalizations alone pay for the vaccines.
Right. It's not even, it's even more impressive than that, because I'm talking about 150,000 hospitalizations per year. However, it's not per year because most of the disease is in the winter. So sometimes it's like the weather when they tell you it's 75 degrees outside, but you feel like 90. So this is actually 150 that feel like 300,000 because
they're all clustered.
Is in the winter. So it's a cluster. We know in our hospital we could not deliver appropriate treatment to those children. They were so much piled on top of each other with 150% occupancy.
Surge.
And now the winter is much more normal. We have more time for children. We do less mistakes. So it's much beyond that. And also pneumococcus is not only pneumonia. So I'm just talking here about respiratory, but it does cause other issues. So definitely, if we look at those 2 vaccines, we knew those 2 vaccines will do something. I don't think that even the optimistic people like me thought that this will do as much as it really does.
I mean, these data are so important for resource nations that are using vaccines to better the health of their community. Do you think that the results that you've seen in children could translate into the adult population when we consider other vaccines that we may be offering adults?
But even this, I mean, what I was talking about was children under 2.
Right.
With the 2 vaccines, but especially the pneumococcal vaccines, 80% of pneumococcal diseases in the community are not in young children.
They're
in all ages, okay,
yes.
altogether. Children, in addition to being protected, they also don't, they have a reduction of carriage of those bugs, and they are responsible, number 1, to transmission of those bugs to adults. So you add to what I told you, you had a very, very impressive reduction in adult disease because we vaccinate children. With rotavirus, it's less known, but the elderly suffer from rotavirus disease, and
well.
also older children. And we have seen already that, not in my study, but in other studies, we have seen very clearly that children, reduction of rotavirus in children reduces rotavirus disease in other ages. So what I told you about the figures, it's just the ones that are vaccinated. It's much more than that in the community.
It's the tip of the iceberg.
It's the tip of the iceberg, and the iceberg is big, and the cut of the iceberg is very big. I think it's fantastic results, and it's not wonder that the WHO thinks that those 2 vaccines our priority now in the world.
So it could be as significant as hand hygiene.
No, nothing is as significant as hand hygiene.
That's good.
You
You
can
won't get in trouble with the WHO.
No. Clean water and hand hygiene is important beyond anything else, but those vaccines are adding a lot on top of it.
We have a question, it looks like, from the internet. Emily?
Yes, we do. We have a question from Josh who posted on Facebook, and he asks, how far is the marketing coverage for these two vaccines?
Is?
The marketing coverage?
Marketing coverage.
I don't understand exactly what it means by marketing coverage. So you go back to the Facebook and ask him what he means by that, and come back to the microphone.
Pardon me?
All right, if he means uptake, we do have it, and we did present it in the poster. We have a very interesting way to look at it. I don't count on the figures given by Ministry of Health or whatever. So as our region is a very defined one, and the hospital is the only one in the region.
Because you can count who gets.
We take first 8 children coming from 2009 when we introduced the vaccines. First 8 children that come in the emergency room in the morning that are under 5 years and their parents agree, we take the details, we go back to the centers, vaccination centers, and we get exactly the vaccination status, and we do it since then. So we have done this, it's continuous, it's 40 per week and 160 per month, etc. And we know that within no time, we got for at least 2 of the 3 doses for rotavirus, we got 90% within no time, and with pneumococcus over 95% with 2 doses at least. So it's a very rapid uptake of vaccination in Israel. Of course, if you don't give the vaccine, they won't help.
And this is part of the normal standard of care for the pediatricians in your region.
Right. It's given free of charge. It's
free of charge.
National Immunization Program, free of charge, given in vaccination centers. It's not the pediatricians who vaccinate. We have special vaccination centers.
And so then the family knows that they have to take their children to be vaccinated if they're going to put them in daycare or send them off to school. They have to be vaccinated against these.
Well, they don't have, we're not like
it's not
in the US.
mandatory.
It's not mandatory, but we get very high vaccination rates.
Okay, what are your typical vaccination rates for these 2 vaccines for the nation of Israel?
Well, it's about 90% or above with 2 doses. If you wait a little bit for the delays, and eventually you cannot do delays with rotavirus because you have an upper age limit. But with pneumococcus, if you wait for the delays, we have for 3 doses over 90, which is the entire vaccination schedule, we get over 90%.
So over the course of this meeting, you've been very, very busy. I mean, you gave a platform talk, you had a poster. So you want to share with us some of your other data that you talked about?
Well, basically, in this specific meeting, I've sent only those data, but the people have been interested to put them in various type of occasions, because those actually contain data from 2 different vaccines. But in general, in the last few months, I've been presenting a lot of our other data. So mainly the effect of pneumococcal conjugate vaccines on other diseases, on otitis media, which is much, much bigger than we thought. The herd protection, or the indirect protection, or the effect on the public health, which is many times more than was predicted, and how the pneumococcal vaccines and the effect can teach us about how pneumococcus cause disease, because we see something after giving the vaccine that is unexpected, and then you go back and you learn from that. So there's a lot to actually present from those data. We learn about pneumococcus every year, a big new textbook every year.
Well, it's interesting. You're probably well aware of what they're terming in this nation as the Mickey Mouse measles outbreak that we had last winter, when there was a founder effect of a measles outbreak at Disneyland here in California, and the net consequence is it spread like the proverbial wildfire, and it was as a consequence of herd immunity. And would you care to give our internet listening audience, because I'm certain that the ICC-ICAC audience well knows about herd immunity, but would you care to share with our listening folks what herd immunity is all about and why it's so important to vaccinate.
So first, everybody talks about herd immunity, herd protection. I don't like to talk about herd immunity, herd protection, because immediately parents think that we think
You don't have to do
the
it.
children are animals because you talk about herd. Okay?
Yes.
We talk about indirect protection. So the idea is if you get injected with a vaccine or get any vaccine, you get immune. You not only are protected from the disease, but you're protected from carrying the organism and spreading the organisms. So if you have enough children getting the vaccine in a community, and the children, the young children from most of the organisms are the responsible for the spread, and they have it less in the nasopharynx or in the stool, that means that the people that contact them will have less exposure and less disease.
A smaller reservoir.
And so if an organism comes in your community, it gets the wall of the infected, or of the vaccinated children, it cannot pass. So me, for example, as a grandfather, who is now more vulnerable for pneumococcal disease than I was as a father,
Right.
my granddaughter, who is full of pneumococci normally, when she kisses me, she has much less of the vaccine serotypes, and I am protected. So this is the mechanism that some people call herd protection, I call indirect protection.
I like the term indirect protection because I think it really drives home the importance of vaccinating populations, because it really sets up that walled city approach to keep the invaders out and to keep their numbers low.
Right. A lot of authorities now and Ministry of Health and people who are responsible for programs, more and more, and in Israel it was for many years already, when we decide about the introduction of a vaccine, we think about protection of children, of course, but we also think about the public health, what the entire public is going to get from it. And I think the first one that did that so was for congenital rubella. So
Exactly.
we gave it to all the children to protect actually their children later on, to prevent
And their mothers who
right.
may have another.
So now we extend it to more, and when people do the cost-benefit analysis or whatever analysis they do, they definitely look at not only what the child gets, but what is the entire society getting out of the vaccine. And this is a big driver now to actually extend. For example, for HPV now, vaccinating boys, not only girls, in order to faster
We've
out of your society.
We've heard that discussion here in the United States about the importance of universal vaccination for HPV. I mean, HPV is a terror to get as an adult when it develops into cervical cancer, and if
it can develop even before you're adult. I mean, it may be faster or slowly, but you also have warts that you want to prevent, and those really are prevented much more successfully if you don't leave pockets of unvaccinated like boys.
Yes. You're watching ASM Live here at ICAC, and I'd like to invite the audience to come up and ask questions, and we have one from your friend from Argentina.
Thank you very much. Excellent presentation, Ron. So I'd like to know that in order to have more data to convince a government authority, do you think that it is possible to make, with your findings, a cost-effectiveness model?
I can tell you, I'll tell you it's my very personal idea or opinion. Cost-effectiveness models can be manipulated and are manipulated all the time by a lot of people interested in one way or the other, so I can manipulate it to sound more cost-effective, and if the government does not want to introduce it, they can manipulate it the other way, and then it depends on the companies, on the producers, on the agenda, etc. So I don't look at it this way in Israel. We are a small country. We have the money to buy the vaccine. But we need to know that we do something good with that and not waste our money. So the Israeli government has agreed not to do for each vaccine cost effectiveness. We have to show them the burden. We have to show them that we can reduce the burden, and we have to convince them that this is not something that we are doing like a crazy thing. So for example, we were the first country in the world to introduce hepatitis A in 1999 to children, because we had numbers that showed thousands of cases of hepatitis A per year. and it went down to less than 100 a year within 3 years. So that's sufficient for us to know that we're investing the money in an appropriate way. Other countries still need to do a little bit more. It depends on the way people think should be, how should they look at how they spend the money.
Another question from the audience, please.
Yeah, thank you. Thanks, Ron, for excellent discussion so far. First, 46% reduction in pneumonia, that's very impressive compared with what you see in clinical trials. And as you know, we've seen that also from other countries as well. What are your possible explanations for that in your setting in Israel?
So we have actually two types of pneumonias, okay? So one pneumonia is the most specific to pneumococcus, which is the alveolar or lobar pneumonia. This is the one we look in our prospective study. It's actually not 46, it's 46% reduction in hospitalization. It's 67% reduction in the outpatient visits, okay? So it's more. Altogether, it's about 55% now reduction in hospital visits. But that's not the efficacy. That's not the effectiveness. This is the impact. So I know that a lot of the audience get confused with efficacy, effectiveness, and impact. But just think, if I reduce from your nasopharynx, or from carriage, if I reduce 50%, which is the number of carriage of the vaccine serotypes in one cohort, the next cohort is going to see only 50%, and it will carry only 25%, and the next only 12%. So we get very fast to a reduction of carriage of the vaccine serotype, and eventually you don't have vaccine serotypes to give to the susceptible patients. So you get a reduction that is much more than the effectiveness or the efficacy. And this is why you see often reduction in pneumonias or in other diseases where the efficacy may not suggest that much, but the impact eventually is very, very much lowered. So again, it depends on the regimens and what type of outcome. So if you look at all-cause pneumonia rather than a very specific one, you see lower reduction, but you still a reduction. In our study, it's about 10% reduction of the other lower respiratory infections, and it's still significant. So my answer to you is, this is why pneumococcus and rotavirus are giving you much better results than expected from efficacy if you take into account that in few generations or a few cohorts, a few years, they see less and less and less, and from each time they have still an efficacy. So it's sort of an exponential reduction at the beginning.
One of the challenges with this conjugate vaccine for pneumonia is what you just said, is you're depleting the vaccine strains from the community, and that may then drive the selection of other pneumococci. Right. So is the next step you begin to monitor what's in our noses so that you can switch out the serotypes in the vaccine?
So the two issues here, okay? First, we do monitor what's in the nasopharynx, at least in our place and many other places. Okay?
Many other places do it as well.
For many years, before and after, and we can tell you a lot about those things. So it's called replacement. And in the nasopharynx, we learned, we didn't expect it too much before, but we learned that there is a niche for pneumococci. And if you take some by the vaccine, because the vaccine only covers a little or several, others come in. So in theory, you should not see reduction of disease, but you see it. Because not every pneumococcus has the same invasiveness and the same ability to cause disease. And it so happened that the ones that were most successful in spreading, being there, and also becoming antibiotic resistant because they were more in contact with antibiotics, those in general as a group, with some exceptions, are the most virulent or the most invasive. So when you look at pneumonia, you don't look at pneumonia with what you don't know. We don't have the bugs. We don't do these steps. Some of the pneumonias may not be at all pneumococcus, but the overall was reduction. If you look at invasive disease where you know exactly the organisms, you see reduction to almost 100% of the vaccine serotypes, and you see some increase in non-vaccine serotypes. And that increase is mainly in the group that is very weak, like immunosuppressed, the elderly, and
the
some
outliers,
because they are still susceptible to less invasive organisms. But the more you have in your vaccine, and now with the 13 serotypes, you are seeing much, much less disease in the overall, the big population of the what we call normal children.
And that's effectively what you saw.
Right. Still, there is a pneumococcal disease. Still, some serotypes are quite invasive. So the thought about either adding another type of vaccine or expansion of the serotype to get to the other maybe 5, 7
The
that
ideal
are
vaccine.
still more invasive is still there, and studies are done to improve. But at the moment, what you see in children, in every country that immunizes, in children under 5, you see an impressive reduction in disease. You see herd protection, as I said, or indirect protection.
Indirect.
And maybe in the elderly, in the very old people where the immune system starts to be very, very problematic and they accumulate a lot of diseases, the reduction is not as impressive because of this replacement. So it's not that it's not there, but the overall is actually, we understand now it's stabilized to be an overall effect that is to be staying with us.
So then, does your study in the pediatric community suggest that for an adult trial, we look at pneumococcus and pneumococcus vaccine and perhaps a flu vaccine to see whether or not that would see similar reductions in hospitalizations?
So it's a combination, okay? So for me, the best protection for the adult is vaccinating children.
But you're a pediatrician.
No. I think this is the data I was discussing. The data show it clearly.
Okay.
About pneumococcus, okay? Still, adults can be infected with vaccine serotypes, but the more you vaccinate the children, the more you have expansion vaccination, and the more the vaccine is a vaccine that causes reduction of carriage, the less you really badly need to vaccinate the adults with this specific serotype that you give to children. Okay, because they will see it less.
You've diluted it out of the population.
Some people believe, and there is some data to suggest, but not yet, unequivocal, that if you vaccinate high percentage of the children with flu, you will be protecting the adults. And the UK is going to try to get many children vaccinated to protect adults. Others think that it's not sufficient, but at the moment, with flu, we are not successful to get this 90-95% vaccination rates, and so we could not prove it, okay? But I think that vaccination of adults is important. It's more important in countries that don't vaccinate, in countries that give a regimen that are not very appropriate, or in countries that have just now started to vaccinate, or if they don't get high coverage. So then it's more important to think about the adults, but in flu, we did not yet reach anything close to protect the adults by vaccination of children, although it might be that when we reach it, it may work.
It may happen. Well, you've been watching ASM Live here at ICAC, ICC. I'd like to thank my guests, Dr. Ron Dagan from the Soroka Medical Facility in Israel, for sharing his wisdom here with us this morning. I'd like to thank you, our audience, for your provocative questions. And this closes this session of ASM Live here at ICC ICAC. Please join us for our next episode at 12 noon, where we'll have our final session at ICC ICAC. And this and all the other ASM Live sessions are available at our ASM Live archive at microbeworld.org. Thanks again, and be sure to tune in for TWIM, TWIV, or TWIP, or our newest podcast, Microbe Magazine, at ASM's website, microbeworld.org, or via iTunes. I'm Michael Schmidt for TWIM. Thank you.
Thank you.
Did fantastic. Thank you very much.
Once you're in the BSL-4 space, the only way you can get out is to go through a chemical shock.
It's an unusual room, never seen anything like this. Anybody who has access to this facility first has to go through an IR scan. So
The HEPA filters filter the air coming out of the facility, and that will remove bacteria, viruses, anything that might constitute any kind of risk, right?
Remember, this building is basically a second building inside the main building.